the virtual platform is active now for all the sessions that are coming up. The virtual audience can actively participate in the sessions by placing your questions. I would like to invite the next moderator to moderate the next session, next topic on the interventional program.
Ladies and gentlemen, may I invite the next moderator, Dr. Mayuruddin, to take the stage. And he will be the moderator for most of the next lectures as well. Dr. Mayuruddin.
Thank you. The next topic will be PCI with ROTA and IVUS live inbox by Dr. Kirti Punamia. May I invite Dr. Stanley Amarsekara and Dr. Vajira Senaratna to come to the podium, please. Dr. Kirti Punamia, very good morning. We are here at Sri Lanka College of Cardiology annual sessions.
Good morning. Am I audible?
Dr. Kirti Punamia, we can see you. We are in Colombo, Sri Lanka College of Cardiology annual session. Very good morning.
Good morning to you all.
Yes.
Let me thank you for giving me this opportunity to present some of my work on calcified lesions over the last few years. Dr. Amar Sena and your entire team at the Sri Lankan College of Cardiology, it's an honor for me to be here on this podium to share some of my experiences. And I'm going to go, without wasting any time, I'm going to go right into our presentation. So up until 2019, our choices that we had for calcified lesions were rather limited, at least in India. If the lumen was adequate in a heavily calcified lesion, most of us would take the green arrow and we'd go directly to a high pressure device like the NC balloon, the OPN balloon, a scoring balloon, or a FlexTone balloon. And all these devices, may I remind you, are all sustained high pressure devices. That means they use high pressures over a sustained period of a few seconds. And sometimes some of them require repeat dilatations to higher pressures in a graduated fashion. And once a complete expansion was achieved with these devices, a DS was implanted. The problem was the critically calcified lesion, which was uncrossable by these devices. And that's what led to, and that is where the role has been for an aggressive rotational atherectomy up until now. And up until 2019, all we had was aggressive rotational atherectomy, followed by the same steps of an NC balloon, an OPN scoring, a FlexTome, and then followed by a DS implant. The limitations with this was that the rotational atherectomy was limited in 90% of cases to a 1.5 millimeter device. And in 10%, we would escalate it to a 1.75 or 2.0. And very rarely we de-escalated it to 1.25. And I'll share those scenarios where we did. The high pressure devices were routinely around 12 to 18, but then we had devices which went up to 30 atmospheres. And the problems with those devices were the entire high pressure, the barotrauma was huge. In fact, in my own practice, even after doing an aggressive rotational atherectomy, I often, in 60% of my patients, I used a FlexTone balloon post-rota, and I'll share some of those cases. Where and how will the new tools fit into our algorithm? And I think the most important tool that has been available to us in this 2020 is the IVL shockwave lithotripsy, which is a pulse HP device with 4 atmospheres as an anchorage pressure and 50 atmospheres of pulsating pressure, which is at 10 cycles per train. And we'll try and see how all this fits into our practice in the current time. So let's focus on rotational atherectomy. I thought it'd be best to put up cases which show different aspects of rotational atherectomy, which we have followed over the period of time. This is an elderly lady with a complex calcified bifurcation LAD diagonal lesion and a critical stenosis of the RC as well. She'd come to us with unstable angina, And if you see a coronary arteries, you can see the left main is partially involved. There's a little distal tapering. Calcium is all around. It's moderate to severe calcification. The LED diagonal is critically narrowed. It's a Medina class 111 with a narrow angle for the LED diagonal. Not only a narrow angle, but the diagonal takeoff is awkward, and it's a difficult wire negotiation angle. And also the RCA, you can see, has a calcified lesion in the proximal and the ostial locations. When you look at these lesions closely, and our area of interest is the LED diagonal, look at this lesion. I think the complexity of the lesion can be kind of assumed because it's so close to the left main. The left main distally is tapered. The entire ostium to the LED, of the LED to the bifurcation point is diseased. And the diagonal is severely narrowed and is taking off at a very awkward angle is seen. So the difficulties we're going to face is difficulty to wire the diagonal lesion. Rotablating the diagonal if it is calcified, and if you have to run the rotablator, the question is how do we do that? And then should we stent the left main ostium, or should we just limit our stent to the LED ostium? I think these are the big questions that come to my mind when I kind of set out to do this kind of work. The answer to this question is, in the previous years, when we tried to enter the diagonal branch, we often struggled. And in that struggle of trying to enter the branch, we would then start dissecting these lesions with the wire itself. And often enough, even trying to get a wire across was associated with vessel closures. So what do we do? By the way, anytime in this presentation, if anybody wants to stop me, make a comment, or ask me questions, just go ahead and just stop me. And I think that's the best way we could learn. So
can you hear me, please? Can I disturb you?
Of course.
Yeah. Now, you have shown us a triple vessel coronary artery disease. Of course, the circ has moderate. Out of the two, LAD has a very severe stenosis just prior to the diagonal, involving the diagonal, and is also RCA as well. So what do you think to handle as an operator, which system you will handle first? Or, I mean, it's the right side you start with or the left side you start with?
Excellent question. So I think the most important thing is that this lady is a 76-year-old lady who has been walking around for a long time and does a 5-kilometer walk. And over the last 1 month, her walk has become progressively limited by angina. And as far as I'm concerned, the most important artery over here is the LAD and diagonal. And that is probably what is causing her the angina. And because of unstable symptoms, it's impossible to kind of go ahead and do any nuclear stress imaging or things like that. But if you look at the RCA closely, and I can actually show you the RCA again, right here. Look at this RCA. This RCA, even though it has a large RV branch, if you look at the LV branch and the PDA, they are small areas. So even though when you look at this angio, it looks like a very large right ventricle, large RCA, I think the distribution, which is effectively ischemic, is much larger in the LAD area. And I think that is the clincher. For me, if I can fix this LAD diagonal and get a great result, and if I can get an angina free, then I would treat that RCA medically, do a functional study once she is symptom free, and only if it is ischemic would I ever come back and fix the RCA. Or if it is a large ischemia with more than 10% ischemia in the LAD, in the RCA region, yes, that's another indication to think of coming back.
Excuse me, Keith. Now I can see the lesion mainly in the LAD going to the diagonal. Distal to diagonal LAD, actually there is not much of a calcium, or you can't see a lesion. So
Right.
basically, if you are going to ROTA, I mean, the thing is, if you can make the way into the LAD to diagonal ROTA, because the distal to the LAD, the diagonal, I don't see any lesion. So basically, if you do a wire from LA to ROTA, I know it's extremely difficult one, but if you, the ROTA purpose-wise, I think you can do LA to diagonal. by doing this, if you able to cross and do it, how safe the procedure if you the rota from LA diagonal, and what possibility of dissecting the ostium and causing difficulty to re-enter the LAD? Because if you just do the LMC towards LAD, distal to diagonal, distal diagonal, there's no lesion distal. So I don't think there's an indication to go beyond the diagonal.
Right.
So if you put the wire to the diagonal and proceed, how safe the procedure?
So one of the big lessons that we have learned is that there are two things. One is, how difficult is it going to be to get into that diagonal branch? You and I both know that that could be quite a struggle when we're talking about a calcified lesion, which is so tight in that proximal LAD, there won't be any room to move around. And in that trying to manipulate the wire into the diagonal branch, there is a good chance that sometimes we could lose the LAD completely. Now, your second point is that you don't see any lesion angiographically beyond the diagonal branch. And what I am going to do is I am going to share with you the IVUS images after we've done what we do. And that would give you a fair idea of what goes on and how much angiography does not tell you just about anything that is required to be known when planning such cases. So my approach in this kind of a situation is go and do the LAD first, rotational atherectomy of the LAD first. And that has been my standard practice. And this is one of the many cases. And that's one of the reasons why I brought this case up, because this is almost always a question that why not just do a rotational atherectomy from LAD to diagonal and then stent that and then just stent the proximal LAD and look at the diagonal, make sure if you can put in a stent, fine, otherwise just a POBA and take it on from there. So this is what we do. A 1.5 burr.
Sorry, if the lesion is not difficult, see the diagonal is a huge diagonal here. You can't afford to lose it. If the diagonal lesion is, the vessel is like a simple one, what do you proceed? What do you do? Go straight from LA to diagonal?
I am going to show you more and more complex cases as we go. So I am going to show you something which is even more complex bifurcation than this. And you will realize how our standard practice is now. And probably what you have raised is actually the question I wanted somebody to raise. But the whole fear is that while doing this, can I lose the diagonal branch? Is that your fear?
Yeah, I know the chances are less, but in case you lose it, the issue actually.
Very less. So if you do rotational atherectomy extremely gently, keep it to short runs. Do not force your burr at all. I keep it at 190,000. And when I do that, I go ahead and I do this.
Just to ask you, what is the burr size of this first one?
1.5 burr. So here it is. 1.5 burr.
You think 1.25 would be a better choice at the beginning or no?
We have stopped using 1.25 because in this scenario, when you start using 1.25, the biggest problem is a stuck burr. All our stuck and stalled burrs have been in the 1.2 because it doesn't have a great ablative surface. So we have stopped using 1.2 unless we are looking at, and I'm going to show you a case, unless it's a straight LAD with diffuse disease or a straight RCA with no tortuosity and diffuse disease. So those are the only two situations where we would use it. And I'll explain to you the anatomy in which I use it. But otherwise, it's almost always a 1.5. Okay. So a very gentle burring, be patient, let's take its time. And then that once it's done, you can see this is your LAD. And note over here, very important when you do this diagonal, when you do this LAD, see where I have placed my wire for the rotablator. I mean, I had two choices. I could go down into this artery right here and put it right there. The problem is, look at the bend here. When you put a wire down a bend like this, because of accordioning effect, you will start having slow flow in that distal LAD, and that increases your ischemia. And some patients start having chest pain because suddenly there's flow not going down below this into the apical branch. So if you can park your wire in a straight branch, that's perfectly fine. You complete your rotational atherectomy. Now there is more space and more room for the LED wire to turn into the diagonal branch. It made our job extremely easy to get into that diagonal branch and then gently rotate into that diagonal branch uh, uh, just at the ostial level and nothing beyond that. This is our rotational atherectomy post-rota ablator. And now we are ready for an IVUS assessment of this artery. So we used a 1.5 burr in the LED, and that allowed us to enter the wire easily into the diagonal. And we have no, I routinely sacrifice. So just because I did a rotational atherectomy in the LED, do I need to keep the wire in the LED? No, we don't need to keep the wire in the LED at all. Even in our left main program, which is now more than 300 calcified left mains, once we do a rotational atherectomy, we are very comfortable to sacrifice the wire in the first branch and then go to the second branch. The whole idea is that when you burr into the diagonal branch, the advancement has to be extremely slow and it has to be sustained rather than the old pecking motion that we are used to from earlier years. So that's important. Now, I think one of the questions that was raised over here was what is and where is the lesion, and can we is it disease free? The LED beyond the diagonal branch. Now, if I have to explain this, this is a pullback from the mid LED down to the ostial LED right here, and then the left main right here. This is a mid LED lesion where we have a landing zone, which is good. And the landing zone is determined by a plaque burden of around less than 50%. You can see that there is and because after rotational atherectomy, we have to do a little bit of a post dilatation we used a flextome balloon to kind of dilate these calcified areas which are present in the proximal LED. You can see that the diagonal branch is right up over there. You can see the origin of the diagonal branch right over there. You can see this is the diagonal branch, which comes out horizontally. And so up to here, the plaque burden is huge. There's concentric calcium deeper. The proximal LED is okay. The plaque burden is around 50% here, but look at the ostial LED and the circ is up there. The ostial LED has a plaque burden of more than 60%. Now the question is, we have to cover this area. We have to cover the proximal. We have to cover the origin of the diagonal branch. And we still have to go and cover a part of this proximal LED into the landing zone, which is almost 8 to 10 millimeters beyond the diagonal branch. Now coming back, how far do we extend the stent into the left main, or do we need to? This is the distal left main, and this is post-rotational atherectomy. And you can see that the plaque burden is huge. And if we try and put a stent here into this area, very likely that you'll have an edge restenosis going forward. So we try to find an area which has a plaque burden of less than 50%, which gives us a fair circumference. This yellow line tells you the area of the plaque, and the area of the plaque over here is almost like it allows us to put in a 1, 2, 3, 4 millimeter stent. So we took in a 4 millimeter stent from the left main into the LED and a small stent distally, completed the job. We did a bifurcation stenting with a mini crush, and we crushed the distal stent, the distal diagonal stent, which is 2.5, with a 3O balloon in the LED. So 4O and a 3O stent in the LED and a 2.5 stent in the diagonal branch. This is how we completed the procedure. We did a pot, and of course, all the tricks of the bifurcation angioplasty have to be met with. This lady underwent a nuclear stress imaging at 18 months post this procedure. She walks 5 kilometers. She's completely asymptomatic. And I think we are going to leave it at this and not worry about the RCA and treat that medically. Yeah. Going forward, I want to present this 65-year-old unstable angina at 6 weeks with an EGFR, which is normal, good LV function. And look at this lesion. This is a circumflex lesion with more than 90 degrees angle. heavily calcified, Medina 111, narrow angle calcified, an OM which goes straight, and then at a right angle, you get that circumflex, and the circumflex is our target. So this is an extremely difficult wire entry, and stiff wires could raise a flap, followed by acute closure. So any ideas on how anybody would approach this kind of angle? Or
We take something like a, PT field XT over microcatheter and have proper gradually advance over the microcatheter and try to, once you cross with the microcatheter, then chain to the wire, rotor wire.
right, so that is our standard approach, and we take a fielder XTR. But here we are. This is what we have in terms of lesion. This is the path that we need to choose. But we could not. We tried everything in the book. We could not pass a run through, a fielder FC, a fielder XTR. None of the soft wires could go because we just did not have room to bend into the circumflex. So what do we do now? We just can't enter. And you can see we are struggling. We have taken a micro catheter. The micro catheter just does not allow us to move that catheter because there's no space to turn the wire into the circumflex. But what easily happens is this, that rather than that, we were able to push the wire into the OM branch. But even though we push the wire into the OM branch is the microcatheter would not follow. It was difficult for the microcatheter, the fine cross microcatheter, to go into that OM branch. So what we did there, we struggled. We could not pass the microcatheter. So what do? So what we did is we took in a Tornus 2.1 French over here. And with the Tornus, we went into the OM branch. And that was the OM branch. Now, once we did that Tornus, we took in a 1.5 rotor blower and we went and did a rotational atherectomy into that OM just across, just partially into that OM branch across the circumflex. Now, what this does is it creates a little bit of room without any dissection flaps, because I believe that if you do a good rotational atherectomy, you don't get dissection flaps as long as you don't drop the revolutions per the speed. And with the 1.5 burr, we achieved that. And once we did that, now you can see with extreme difficulty, I anchored my wire into the origin and then advanced that microcatheter in the first frame slowly. And once I got my microcatheter there, I was able to advance a fielder XTR into that lesion in the circumflex. Now the next question is, I cannot advance that microcatheter into the circumflex. So any ideas for me? Any thought processes?
To get to that most difficult, like as much you can advance, and then use your rotor wire to proceed.
So that's a great job. So that's a great point, and that is a great point to remember. Once you can anchor that microcatheter, remember the only thing that you got to remember when you do that is, if you can, there is an acute angle here, and this acute angle stores energy. The minute you remove this wire, you will find that sometimes the microcatheter will flip. So typically with this wire there, once you have this, try to smoothen this curve out a little by pulling the microcatheter back just tight slightly. And then once that happens, I think, yes, you can see what we're doing there. We are actually smoothened out that curve, and we are taking a rotor wire into this circumflex artery, holding it steady in place. And once we've done that, make sure that you examine your microcatheter. If you struggle too hard with your microcatheter, and if you start rotating the microcatheter, sometimes your tip can look like this. The tip of the microcatheter can get mangled up. So be very gentle with the microcatheter. Therefore, the only microcatheter I use is a fine cross or a Tornus. The Tornus is a metallic tip, so it's much better in this situation. However, I see a lot of people using the Caravelle and the Corsair. Those are extremely dangerous catheters in this situation because the tip can get fractured or even mangled and get stuck in that ostium, and it can break the tip. So this is an important thing. Just be careful, because these kind of microcatheters are very difficult to see angiographically. And if you don't see it angiographically, and if you advance it too far down into the artery, you can cause ruptures because of these wires which have braided into the system. Can you see it very well on my screen? Once that is done, we do a rotational atherectomy again using a 1.5 burr. The speed is around 190,000, which is standard in my cath lab for me. And we needed to use almost 250 seconds of rota time. And once we did that, we crossed this lesion. Now, once we crossed this lesion, this is what it looked like. You can see that the branch OM is good. Now, even though that's there, you still have difficulty tracking a stent beyond this point. And so we have to protect that ostial left main plaque, because in doing that, the last thing you want is to dissect that ostial left main plaque. So for me, a Guidezilla at this point is standard. It helps me protect everything else, and then gives me a landing zone. It's easy for me to use balloons, dilate that lesion further, create a lesion bed, and then place a stent. And this is our final result. And this patient has been doing well. This is almost 4 years or 5 years old now. Any questions on this case?
It is usually the LAD, when you are doing ROTA, we don't put pacemakers, but for right coronary circumflex, we generally use a prophylactic pacemaker. Is it not your practice, sir?
Okay, so that's great. So in my dominant right coronary artery, I would use a pacer, yes. In my left main, which is dominant, codominant with a dominant circumflex artery, I would use a pacer. Sometimes in a proximal ostial LED, which is type 3, I would use a pacer. But otherwise, in all other situations, we do the first run. And if in the first run we don't have any bradycardias, we don't even think about a pacer. But what we do have is a clamp. We use the rota wire as a unipolar pacer to use for pacing. So what we do is we take a pacer, put the negative onto the distal wire of the rotablator, and the positive we attach to a hypodermic needle and put it under the skin and connect it to the pacer, and that works very well.
Great point.
So you don't need to have pacers in all these patients, because, and even when we use a pacer, we only use a balloon inflatable pacing pacing wire, the 5 French balloon floated one. We've stopped using the normal pacers.
Kirti, you're using the femoral approach. Would you
Yes.
be using the radial as well for this?
Yes, so we don't care if the radial is good. If I have to use these 7 French guiding catheters, sometimes I have a Doppler right in my cath lab, so I just look at the radial artery, and if I see no plaque or calcium, I just go radially. I look at the radial artery, I look at the cubital artery to see if there's any loops of the radial, and more so sometimes the biggest problem is not all this, is a lysoria or a tortuous subclavian artery, which is one of the biggest problems. And the last thing you want to do is struggle along those lysorias and have great difficulty in having good guide catheter positions when you're doing an already difficult case.
Usually ROTA, when you do ROTA, you get with the prolonged ROTA, also ROTA long segment, you may have slow flow, and you get ST changes, pressure dropping. And what is the usual now? Most of the Asian patients, we have a very long disease in the LAD. So you have to ROTA the big length. And how do you tackle that sort of?
So I'm going to show you that. So I knew that would be the automatic question. So we put cases for that.
Kirti, another thing is that the rota fluid, the liquid that we are using, how much GTN, verapamil, and this cocktail is being used?
Last 15 years, we've never used any vasodilator in that flush. So it's normal saline, and we use 2,000 in 1 liter flush. We use 2,000 units of heparin. And now we put just 0.5 milligrams of GTN in that. That's it. We just don't use calcium channel blockers. I believe that calcium channel blockers cause hypertension, and they don't do any good at all. I think rotational atherectomy, the technique is far more important. We have better antiplatelet agents, so that's good. The most important thing in rotational atherectomy is left ventricular end diastolic pressure. So in all these patients, try to measure the left ventricular end diastolic pressure. If the left ventricular end diastolic pressure is very high, and if the blood pressure is around 110 by, say, 80, and your end diastolic pressure is 25, then what happens when you start doing rotational atherectomy? You cause ischemia, you cause hypotension. And when that hypotension happens, the diastolic pressure would go to around 60 or 50 sometimes. Your end diastolic pressure goes up, it goes to 35, and then your coronary flow or coronary perfusion pressure drops. That is the reason why you get slow flow in those patients. Also, I see that people are in a rush to complete the rotational atherectomy, so they're pushing their burr, and therefore there's huge drop in revolution. So I think very, very important, don't do those things. But you know, that the hemodynamics in rotablator are very important. And as we go along, we'll show you that when you have suboptimal hemodynamics, we have very little hesitation now in putting people on Impella or a balloon pump or on a noradrenaline support through the procedure, so we have a better perfusion pressure at least going forward. End diastolic pressures, when they are raised, we have to treat them with diuretics and we have to start dobutamine. If the end diastolic pressure is low, then the minute you give nitroglycerin to these patients, there'll be a drop in blood pressure. So it's very important to hydrate these patients and maintain an optimal left ventricular end diastolic pressure during your rotational atherectomy. So we'll go on to this 85-year-old whose GFR is low, good ejection fraction, and look at the calcium. You can see the huge calcium, and this is the left coronary artery with a CTO to the right, and she has angina. Now this CTO is bad because I tried a lot of diagnostic catheters and nothing would engage. They're all very difficult because there's a blob of calcium sitting right at the origin of the RCA. Now it's very difficult to engage this with any diagnostic catheter. So, wait a minute. This is just mix up of slides. So what has happened over there is, well, just give me one moment. Let me just rearrange these slides. Just give me one moment. Yeah, let's go back. So this is the right coronary artery, and this is extremely difficult, and this is a CTO. Now the problem is, we tried many guiding catheters, 4 different guiding catheters, JR4 Lima, AR1, AL1, everything, nothing would engage. So the only way we could enter this coronary artery is reflecting that JR4 catheter, and then, you know, almost fishing for the right ostium, and you can see how we got a wire inside. Once we had a wire inside, we followed it with a microcatheter, and this angiography is done through the fine cross microcatheter to define the proximal cap. Once we do that, it's difficult. Now, how do we approach this? Because it's calcified. So we put in a microcatheter. With that, we tried the wire to cross the lesion. The minute we try to engage that lesion, everything just flipped up, and the next thing, all these things were in the cranial artery. It was difficult. Any suggestions on what I could do to help myself in this? What would you do in this scenario? Hello?
The catheter.
I mean, the guiding support. I have no guiding support. I cannot even engage. And I have a CTO, which is after a bend in the RCA, which is calcified, heavily calcified.
What about the IR catheters?
So we tried
IR is a good option.
Yeah.
IR is a good option, which you can get into the vessel actually. Only thing is, I don't know, with the pressure dam, there are no side doors in the IF, the catheter. But when you can enter, you can gradually advance to the vessel, to the distal part of the vessel, the IF.
IR.
So what I did was, that's an option. What we did is, what we do now routinely is, we take a JR4-7 French. Along with that, we take a Guidezilla 6 French. In that, we put in a fine cross. And then with that, we took the Feeler XTA. And that's the Feeler XTA wire. it couldn't penetrate. So then we used a Gaia. This is a Gaia wire which is actually crossed. And once we did that, now the challenge is that the fine cross microcatheter is stuck at this point. It won't advance beyond this point. This is where the fine cross microcatheter is stuck. It won't go anywhere beyond. So again, we fall back, we change that, we change that microcatheter, and we get in a, you can see that we get in a Tornus catheter. And now this is a Tornus, this is a 2.6, this is a 2.1 French Tornus again. And the Tornus allows you to screw into that catheter, because in these cases, if you try struggling with the microcatheter, you can destroy the microcatheter and you can unbraid it, causing perforation. So we have the Tornus here. Once the Tornus is here, so we have the guiding catheter, in that we have a guidezilla, in that we have a Tornus. And so now the Tornus, we have removed the wire. And once the wire is removed, we then can replace it with a ROTA wire. Now, very important here, that when you have a very difficult ostium, don't try to take your guiding catheter right to the ostium, because the minute you do that, you'll drop your pressure. And when you drop your pressure, you will then have slow flow, and then this rotational arthritis, you start having slow flow with distal debris because the temperature goes up. What I do is I keep my guiding catheter in the sinus in the opposite direction and create a loop, and that loop allows me to do a rotational atherectomy coaxially into the ostium, and this way the coronary flow is not compromised, and it allows you to go right into the coronary artery deeply, and we've done cases right into the bifurcation using this technique for difficult osteal locations. Of course, we then go ahead and use that. Once the rotational atherectomy is done, high pressure dilatations, guidezilla assisted stent deployment, and on the way out, always look at the ostium using IVUS, and if the IVUS shows that the ostium is without any issues, go ahead and leave it alone. Now this is 3 years down, this lady is doing well. So here is a great case where we thought that we could show you that it's not always important to have engagement of the guide catheter. And even after we finished it, can you see the guide catheter is still outside in the aortic sinus? We put in a diagnostic 125 centimeter diagnostic catheter, or we could even do it with a guidezilla. You take the final angiogram, and that gives you a complete assessment of what's going on, and you can complete your case. Any questions on this one?
When the wire is, so the microcatheter is not moving, you didn't try the pre-dilatation with any balloons?
No, we don't do that, because the problem with this is when you try to pre-dilate, for pre-dilating the balloon, you need to cross it with a balloon. When you have such poor support, it's very difficult for me to even imagine that I'm going to be able to get a balloon down there. So once I had the Tornus down there, it was safer for me. I wanted to cut down one step and say, let me just do a rotational atherectomy. And because once I know I get my rotational atherectomy burr down there, I am going to have no problems. Now, it is possible. This December, very likely that we are going to get a laser. And if there was a laser in my lab, this is a great case to have a 0.9 fiber laser going into the right coronary artery, ablating it, and then going ahead and doing your balloon dilatations. But short of a laser, it's difficult to use any other existing technology at this present time to successfully do these cases.
Have you got lithotripsy as well?
Yes, and I'm going to show you some cases with that. Yeah. How are we going on time?
20 minutes more.
Okay, great. Excellent. So I'm just going to go through these difficult scenarios. Now, this is a difficult scenario. This is an undilatable lesion in that RCA. It's a shepherd crow. I'm sure a lot of you have faced this kind of situation where there's a tortuosity, but the calcified lesion is beyond the tortuosity. Now, how do you tackle this acute bend and do a rotational atherectomy for that lesion without compromise? The problem with these kind of lesions is that if I look at my past experience, then my past experience tells me that when I had a case like this, and when I do a rotational atherectomy in that right there, the wire takes the lesser curve, and then you start seeing these kind of neolumens. These are associated with very high perforation rates. And that is the problem with this scenario. So how do you tackle this acute bend? Any ideas of what I should do in this? Because the previous operator This patient was from Dubai and flew down here because they tried everything in their cath lab, but they just could not dilate this lesion, and nothing would cross except for a balloon. And once the balloon was inflated, if you had to recross it, it wouldn't recross.
I just couldn't answer why couldn't you cross this?
We could not cross it. We could cross it with a wire. No balloon would cross otherwise. Once you only a new balloon would cross, and once you inflate it, try to inflate it, and you lost its profile, it wouldn't recross. That's what the operator note said. Now this patient has come to your lab, and we need to do it. So any ideas how we would approach
Why
it?
can't you do ROTA?
So the problem with the ROTA is because of the acute bend. Can you see this acute bend? And when you have acute bends like this and you do rotational atherectomy in the right coronary arteries, you start getting neolumens. Can you see that neolumen on the right over there?
When you put a
Floppy wire.
And this
ROTA
is with a
floppy
floppy
wire.
wire. This is with a floppy wire. Whatever the wire. See, remember the wire is floppy and it's soft. But when the rotational atherectomy burr comes, the shaft of the burr is quite stiff. So that makes the entire assembly quite stiff. So when the burr comes in, you can see that the burr actually straightens that curve out. Can you see the burr straightening the curve out? And then you start getting neolumens and increasing your perforation rates. So what I do in my practice now is I put in a wire, and once I put in my wire in with a microcatheter, we go with a fine cross, and I put my guidezilla in that. And once I take the guidezilla across the bend, I can now go ahead and do a 1.25 burr through the guidezilla, keeping the same approach of keeping a loop in the aortic sinus. And this is how we do. We've done around 4 or 5 cases this way, and they've all turned out well. We keep you can see that we put a balloon floated pacing wire in this RV for this case. This is a 1.25 burr. So the only burr that will successfully do it through the guidezilla is a 1.25. You cannot take a 1.5 burr. So once we did that, we then use a flextome balloon and dilated this lesion. And then using the same, we did an IVUS. And then once the IVUS was done, we put 2 synergies. And this is our final result. So I think this is another trick that you can use in a tortuous artery if you want to protect a proximal tortuosity. Any questions on that?
The guiding catheters, what you are using is accompanied with guidezilla. What you are using is keeping the guiding catheter out.
Well, normally for these patients, I would take a 7 French guide catheter and then take a 6 French guidezilla so that it gives you good, you have enough room to move around in there. If you took a 6 French guide and a 6 French guidezilla, there's hardly any room to move. And then it is very difficult to measure the aortic pressure over here, because through the guidezilla, you see damped pressures. So you need to measure your pressures from this guide catheter.
Are you using the side hole ones, the end hole ones for
No,
the CTOs?
I don't use side hole because it's a waste of contrast. I don't use side holes at all in my practice.
Okay, right. Thanks.
So this is a 62-year-old lady who came with an acute MI. This is the calcified lesion, bifurcation lesion, large diagonal. Came in at midnight. A senior colleague of mine took on this case, and they tried multiple things, but struggled for almost 2 hours, almost 1 hour into this acute infarct, and just could not cross that LAD. For some reason, nothing would go in. He thought he's going to lose flow in there, so he got his wire in and he put in a stent into that diagonal branch. There was a little bit of relief because the diagonal flow was better. I mean, 2 arteries were compromised, now only 1 is compromised. Patient was hemodynamically better, but continued to have chest pain, but he had jailed the LAD. Now, this is a calcified LAD which has been jailed. Now, the surgeons were called in, and this patient was getting prepared for surgery. They ran it through me, and I thought that we should give it another chance. What would most people do? Should you give it another chance? Should you send him for surgery? Or what would one do?
You put a pot and try to cross the lesion, and then
Do a
dilate the
pot.
lesion.
So what we did was we got this patient the next day. I need just 10 seconds to, I think my battery is going to load. Just give me 10 seconds and I'm going to put it on my charger. Yeah. Good. So this is the flow the next day. And when we had this flow the next day, the first thing we did was we put in a wire through that. There's a normal run through wire. And then very gently, with a counterclockwise or clockwise rotation, we just went into with a microcatheter just across the strut, but it wouldn't go any further. You could see it's backing out the guiding catheter. So with that, we put in a rotational atherectomy wire and then used a 1.5 burr very gently across the struts and did a rotational atherectomy into that mid LED through the struts of through the LED stent. Now, once that was done at 190,000, this is the IVUS. This is the IVUS pullback, and here you can see images from the diagonal branch. It's a 3.0 stent coming into the LED. The proximal LED shows that it's a large area with 9.4 millimeter square area, which is 3.5 millimeter artery. And the ostium of the LED was significantly narrowed, which was missed by the operator. The angiography did not show this ostial lesion. Now, this was the IVUS pullback. You can see that this was the distal landing zone in the LED. The LED landing zone down beyond this was right down here. You can see that this is 6.5 millimeter square, which is a little over 2.5 millimeter artery. It comes here. This is your diagonal branch here, which you can see at the confluence of the LED diagonal. And then a proximal LED, we put in a stent. This was partially under dilated, so we had to go up on a higher pressure over here. Finally, after concluding this case, this is the final result. We fixed it with we converted this into a culotte and then did a final kissing balloon, got great results. And this patient is now out 15 months after the procedure, walking 5 kilometers with a normal ejection fraction. So we've had a fairly large experience on doing rotational atherectomy across the struts of a stent. I think there are two things. Never take a smaller burr, always take a 1.5 burr. And two, 190,000, and sometimes you may have to go up to 200,000 revolutions per minute for these cases, but you've got to not push, you've got to let the burr do the job. And between the runs, you need to have a substantial amount of time, almost 60 to 90 seconds between two runs, so that the burr can cool down, because the burr becomes extremely hot in this. And if you do repeated runs with short intervals, you can actually start coagulating tissue, and that's what causes the burr to be stuck in that situation. So it's a very, very important lesson to learn. Any questions on this one?
I mean, one question is actually, when you have got acute MIs, generally there's evidence, there's clot burden there. We are scared to put the PROTA. Of course, when there is hardly any thrombus, even with the balloon, you can see no flow setting. So how safe in acute setting to use ROTA in your practice? How often use in acute setting?
So
ROTA,
from 2000, we're just writing up a paper for the Indian Heart Journal, and hopefully it'll get accepted in one of the international journals as well. From 2007, we've done approximately 35 rotational atherectomies in STEMI. We've got around, of those 21 patients, we've got all the data. And in the last 12 patients, it's been IVUS guided, like in this case. We're very comfortable doing it in certain situations. And in those cases, especially in STEMI, in the elderly with calcified lesions where nothing will go, the thrombus burden is large. And if there's a huge thrombus burden, then you cannot do rotational atherectomy. Then the only technology that we have is either the IVL balloon or the laser. And we don't have the laser at this present time. But those patients, we would just do a balloon dilatation, establish flow, and get them back later. But if there's if the thrombus burden is not large, we have a fairly large experience now. In our experience, we are not scared to do rotational atherectomy even at 1 o'clock in the morning if we have to do that and get a great result in these patients. But we have to be extremely gentle. We need to have abscesimab on board. We need to have optimal hemodynamics.
Kirti, I have some virtual speakers have sent some questions.
Please.
Sorry, virtual delegates.
Yes, please.
When do you decide to use coronary lithotripsy over rotablation in calcified lesions?
Great. How much more time do we have so that we can just go
We
on
have about 7 more minutes to go.
Excellent. So if that is the case, let me just skip forward to some of those last couple of cases, which will tell me how I decide on these cases. Okay. So just 2 cases I'm going to show you, which are interesting, and I'll go through them a little more rapidly than I did earlier so that we can cover both because they will be interesting for you. So this is a gentleman, 60-year-old, unstable angina. You can see the history, diabetic, and this is the angio. You can see a significantly calcified left main. You can see it's a trifurcation going into the circumflex and marginal branch. Now, if you look at the CT scan, you can see the CT scan calcium distribution. The ramus is without major calcium, but the LED ostium diagonal, everything large, and the LED ostium is eccentric calcium, very large piece of calcium. Now, how do we look at it? This is my cartoon representation of this anatomy. And my first thing is we do a rotational atherectomy into the circumflex artery. And once we do the circumflex artery, how do we view it? We do an IVUS run from here and look at these images from these cross sections. We do an IVUS run from the ramus and we look at cross sections from here. So where do we land this? The question is, where do we land the stent? Do we take a long stent, short stent in the OM? Do we have to stent the diagonal? So when we look at the IVUS images, you see that the circumflex is 2.6. The OM is 2.9 millimeter branch. So these both are very significant branches. You can't lose any one of them. Now, when you look at when you come to the branch points of these 2 lesions, you see there's a very large plaque burden at both ends, and the carina is not free of disease. And therefore, if you put stent in any one artery, and leaving the other, you're going to lose the other branch. So there's no question that you would have to stent both. The ostium of the circumflex shows this much like a calcified nodule down with soft plaque around it. And this is the distal left main. This is the distal, the OM proximal landing zone, and this is the OM. So the question is, should we put in a short stent in the OM, just a short stent? It would land in this area, making it extremely high risk for recurrence, and it would be a very small size stent. So it's better to extend the length of the stent so that you have an adequate size of the length. Now, having got all this information, we do an LED pullback. And this is the LED pullback, and that's the left main. Now here, even after we've not done a rotational atherectomy in the LED, but what you see is a deep calcium. The catheter is right in the center. Now, doing a rotational atherectomy in this kind of a situation is of no use because a 1.5 burr or even a 1.75 burr will only swim through this and there will be no impact on this calcium. So in these kind of situations, what I do is I would then take, this is the IVL balloon. And this IVL balloon at 60 pulses, cracked it up. After that, we took a 4-0 cutting balloon to dilate it even further. And you can see how we found that the calcium that is there has cracked with the IVL balloon. And now it was easy to place stents. So here it is. This is our anatomy. Our first stent is going to come this way. And then we'll do a pot proximally. And then this is it. So that's what we did. So you can see that we have put a stent right from the ostium of the circumflex into the circumflex. That's our first stent done. Now, through the start of that stent, we go into the OM branch, open the OM branch, and that is our second stent going in from here, which is like this. And once our second stent is gone into the ramus, we're going to dilate the proximal part over here, and we're going to dilate this with a 4.5 balloon based on the IVUS sizes. And once we've done that, now we have triggered ourselves for the third stent to be placed here. And that's what we do. We finally go and dilate with a kissing balloon. We've done our first kiss when we finished this with the circumflex and OM. And our second case was between the OM and the LED, which you can see right down there. We completed this case. And now this is these final pictures. The only pictures we found that the circumflex ostium was still a little undersized. So we took in a larger balloon at a higher pressure and dilated the osteomotor circumflex and got a great result. This patient has done well. This was
Question now.
finally. Please tell
Now,
me.
this situation, actually, the most important vessel is the LAD, and
Yes.
whatever it is, the circumflex side branch.
Yeah.
So, if I would have actually done both circum and put drug-eluting balloons to both ways and put the LAD stent, but more stents always cause more problems with stenosis. So,
I can't hear you. I'm losing you.
no, I'm just telling the most important vessel is LMC to LAD, the most important vessel, the circuit side branch. Why shouldn't we do dilate the circ optimum and put drug-eluting balloons to both the circumflex and OM rather than putting 2-3 stents, which might cause future problems like this stenosis and all that. The drug-eluting balloon is they are in a big way in other countries now.
Yes, I know drug-eluting balloons are in a big way in many countries, but most of them are under trials. And when you start having such calcified lesions right at the ostium, which are significant, and if you, I'm not sure about the long-term results of those. It may be the technology for the future. It may be a technology that we could use maybe going down the track. But at this present time, I think how to finish this case off, whether we do a single stent into the from the LED to the diagonal, which we've done in many cases, that's what we do. The question is whether the drug-eluting balloon, will it work or not work? Are the TLR rates going to be low enough with the drug-eluting balloon vis-a-vis a stent? I just don't know that answer at this present time. If I look at a single data from one of the Singapore hospitals, Paul Ong's work, they had a 1-year TLR rate of around 7 to 8%. Now, 7 to 8% in a straight non-branching lesion is very high. Our own experiences with the drug-eluting balloon in the distal LAD in this area of the apical branch of the LAD is good. But whenever we've used it in a circumflex or whenever we've used it in these branches, typically, I can show you cases and cases where they've shut off in 6 months, those arteries are shut off again. So we'll need to know data before we kind of jump onto using drug-eluting balloons in these important areas. But when you start using trifurcation stenting, you've got to be very clear into how you're going to finish the case and what result you're going to give. This patient is doing well now for almost a year without symptoms, walking
Sorry to disturb you, Kirti. Your time is going to be up in another 30 seconds.
Okay.
And
so I am going to just go to just a very last thing that in these patients, in moderate to severe calcified lesions and ISR, these are the two calcified areas that we see. Now, most of the times, a CT will help to assess these arteries. Now, imaging is the first thing that we need to do, but most of the times the imaging catheter cannot cross. So you need to do something. Now, you try to see a ROTA wire going across. If it does go across, use a rotational atherectomy 1.5. If it doesn't go across, you have the tornus, or you can use the ELCA, that is a laser, or an orbital atherectomy, both of which we don't have at this present time. We have the tornus though, and that's what we've been using. But once we have something like that, we put in an IVUS imaging catheter. Once the IVUS imaging catheter is there, we define the lesion based on variety of descriptions. We look at the assessment of wire bias, we look at eccentricity, and we look at fracture of calcium, whether it's there or not. Once we have these imaging, if you see a concentric lesion like this with an arc more than 80, what we do is we do either high pressure balloon with an NC or a flextome, and if it doesn't work, we go to lithotripsy. In a few cases now, we've gone directly to a lithotripsy as well to save cost and to make it easy. In these calcified nodules and eccentric calcium, what we have, we look at wire bias. If the wire bias is favorable, we escalate the burr size. If the wire bias is not favorable, then the burr size is not, escalating burr is not going to help. We have only one choice, the high pressure balloon and the flextome. What is the ideal technology for this? Is orbital atherectomy or laser? We really don't know whether we have a good answer.
Just allow us to thank you first, because the time is going to be up and suddenly you may get disappeared. And you did a wonderful presentation and a good discussion and a very well done. And we had a good interaction from the audience, virtual and as well as physical. And thank you so much for joining us with Sri Lanka College of Cardiology sessions of interventional meeting. And I know it's fully worth listening to you and having a discussion. Thank you so much.
It has been a pleasure to be with you guys. Yeah. I hope you have a great meeting.
Thank you.
Bye.